two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checco from India.
Welcome to eCritCare Podcast. This is our episode number 100, and today I'm joined by my co-host, Dr. Jose Checco. So Dr. Checco, first of all, congratulations and thanks for all the hard work for last almost 3.5 years. And it's quite a milestone and achievement to complete 100th episode of this very popular podcast.
Thanks a lot, Swapnil. It's been my pleasure, and it's been a great experience to join hands with you with this broadcast. I'm sure people all over the world would have found it a useful source of information, and hopefully we can pursue this for a while.
Absolutely. And I guess this podcast obviously inspired us, to another important contribution to field of critical care, that is the book Critical Care Controversies, which will be out soon. So I guess where we started and now where we are heading, it's quite amazing, I guess. So reflecting back on this journey, it has been a very satisfying and rewarding journey overall. And again, looking forward to recording many more episodes in the future.
Yes, I'm certainly looking forward to it.
So I guess the controversy that we've chosen today for our 100th episode is about one of the most commonly used drug in intensive care unit, that is oxygen. Now, oxygen is so ubiquitously available in every hospital and intensive care unit, and almost it become our second nature to put every patient on oxygen comes via door of intensive care. Initial use of oxygen was although started for patients who were hypoxic secondary to pneumonia. Over the period of time, it became that more of a prophylactic use of oxygen in the hospital settings. And one of the common example is when the patient gets prescribed on patient control analgesia, just to avoid them becoming hypoxic secondary to hypoventilation, we mandated using oxygen therapy in patients who are requiring PCA for pain management. And that's sometimes quite contradictory to what the literature told us about use of oxygen. And I guess there is this kind of fear that patients get put on oxygen and then they develop hyperoxia, because we also became aware of this phenomenon of free radical induced injury over the period of time. And I guess that was a concern with the ubiquitous use of oxygen in intensive care unit or in patients who are critically ill, because probably the damage associated with increased use of oxygen is probably more than the actual benefits. So I guess, Dr. Checco, the first and foremost question is, what is hyperoxia? And how do we define it?
Yes, hyperoxia implies exposure to higher than normal levels of the partial pressure of oxygen at the cellular and tissue levels. Conventionally, a liberal approach to oxygen therapy is favored by many clinicians as a preventive measure, as you mentioned, against inadvertent hypoxemia. Pulse oximetry to identify hyperoxia, because you get an upper limit of saturation and still you wouldn't know what's going on with the partial pressure of oxygen in the blood or in the tissue. So that's a drawback of oximetry. And even if your patient is saturating only 98% or 99%, the PO2 could be quite high. So the normal PO2 levels, of course, is 80 to 100 millimeters of mercury. There are various definitions for hyperoxia. A PO2 of 100 to 125 is considered to represent mild hyperoxia, while levels more than 200 represent severe hyperoxia. Definitions are variable, but regardless of definitions, anything higher than normal in most circumstances can be an unsafe situation to be in.
Yeah, that's right. I guess one of the problem with the definition of hyperoxia is still we do not have consistency and a standard definition of hyperoxia. And that's why most of the trials that are conducted using various definitions probably gave us different results. And I guess probably at some stage we will need a unified definition of hyperoxia. So at the moment, I guess PO2 of more than 100 usually considered to be hyperoxia. And even though it's mild, but that's probably we want to aim for PO2 of less than 100 when patient is on oxygen therapy. And I think we should be able to target PO2 between 60 to 100 in most of our patients in ICU. Having said that, why do we fear about this hyperoxia? Or in other words, what are the kind of physiological consequences of hyperoxia?
The basic problem with hyperoxia is that the oxygen molecule has the unique property of being an electron acceptor. And when it accepts electrons, the newly accepted electrons remain unpaired and become oxygen-free radicals. And when they take part in biological reactions, they represent the reactive oxygen species, otherwise known as ROS. And they normally play an important role in the eradication of mutated or damaged cells. That is through a process called apoptosis. But when the oxygen levels are excessively high, hyperoxia result in rapid overwhelming of the antioxidant mechanisms that are normally present in the body, which leads to killing of normal cells by the reactive oxygen species, which result in harmful effects in different organs, including the lung, where you can get loss of ciliary reactivity, tracheobronchitis, absorption collapse. And then, of course, the oxygen inhibits nitric oxide, which is a naturally occurring vasodilator. That can lead to a vasoconstrictor effect in most organs, excluding the lungs. Coronary vasoconstriction may ensue, leading to myocardial ischemia. And then, of course, the very common problem that we see in patients with hypercarbia, COPD patients who are carbon dioxide retainers, who develop even worse hypercarbia with oxygen administration. This is not commonly because of inhibition of the hypoxic drive, as people tend to believe. It's mostly due to the abolition of the hypoxic pulmonary vasoconstrictor response. So whatever the case may be, you do see patients who are hypercarbic at baseline become even more hypercapnic when you administer oxygen, because they tend to have a failure of the hypoxic vasoconstrictor response and an increase in shunt across the lung. So these are some of the common adverse events that can happen from excessive oxygen administration, or oxygen administration in situations where you don't really need to give it.
Thanks, Dr. Chakkar. So I guess oxygen is clearly not a very harmless drug, and it can be associated with a lot of other side effects. And even in the neonates, we know that it can cause retinopathy in a premature babies. So I guess it's even in adults, I guess with certain diseases and conditions, oxygen can be potentially harmful. So what's the kind of clinical evidence to guide our practices at the moment?
Several controlled studies have been carried out in the last few years, which is a real eye-opener to what may be appropriate levels of oxygen in your patients whom you come across by the bedside in the ICU. One of the early studies was in myocardial infarction, a randomized controlled trial which was carried out by the ambulance service in Melbourne, Australia, in which they supplemented oxygen to patients who had ST elevation myocardial infarction, who had a saturation of less than 74%, were given oxygen, supplemental oxygen. And on the other arm, they accepted saturation of up to 94%. So in these patients, they found that supplemental oxygen, in fact, led to an increase in the infarct size at 6 months on MRI imaging. Besides, there was a higher incidence of recurrent myocardial infarction and arrhythmias with the use of supplemental oxygen compared to not using oxygen at all, provided the saturation was 94% or more. So this was one of the early studies that suggested that in patients with ST elevation myocardial infarction, you might actually cause harm by administering supplemental oxygen. And there were several studies in the last few years in the ICU. One of the first was the Oxygen ICU trial, a randomized controlled trial, which was carried out in a single center in Italy. They randomized patients who were in ICU for longer than 72 hours to a restrictive strategy with a PO2 level of 70 to 100. That was the conventional or restrictive strategy. And in the more liberal group, they would allow PO2 levels to go up to 150 millimeters of mercury. And this study actually found a significantly higher ICU mortality with liberal oxygen therapy compared to a more restrictive strategy. We had the ICU ROC study from the AN6 group, in which they randomized patients to a restrictive arm with saturation ranging between 91 to 96%. And in these patients, they would actually turn down their 5O2 to 0.21 or 21% if the saturation level was indeed between 91 to 96%. In the liberal arm, usual care was followed with no specific interventions and the saturation was maintained between 91 to 100%. That is sort of standard care. And in this study, they did not find any difference between the restrictive and the more liberal strategy in terms of the ventilator-free days at 28 days or the 90-day or the 180-day mortality. A couple of things that they noted. First, in patients with hypoxic ischemic encephalopathy, they seem to fare worse if they had a liberal oxygen strategy. And in septic patients, there was a trend towards improved 90-day survival with a more liberal oxygen therapy. So that was the findings of the ICU-ROC study. Then we had the French Hyper-2S study, which was carried out in patients with septic shock, wherein they maintained a saturation of 88 to 95% in the restrictive arm, while in the liberal arm, they maintained their FiO2 at 100% for the first 24 hours. This is, of course, among patients in septic shock. So 100% for 24 hours was a little bit too high. And I am not sure as to how the study got ethical clearance with this sort of strategy. And predictably, they found a higher 20-day mortality in patients who were maintained on 100% oxygen for 24 hours. So that study obviously showed that this strategy of 100% oxygen for 24 hours could lead to harm. Then the LOCO-2 trial was another study conducted in France, wherein they targeted a PO2 level of 55 to 70 in the restrictive arm, saturation 88 to 92%. And in the liberal arm, they maintained the PO2 between 90 to 105, saturation levels 96 or more. They did not find a difference in mortality at 28 days, which is the primary outcome, but they found a higher incidence of mesenteric ischemia in the conservative arm, where the PO2 was aimed at 55 to 70, saturation 88 to 92%. So mesenteric ischemia in this restrictive arm. So based on this finding, the study was stopped after enrollment of only 205 patients due to safety concerns. So this study seemed to suggest that a low PO2, 55 to 70, might cause harm in terms of mesenteric ischemia. Then we had the HOT ICU trial from Europe, 35 ICUs, including Denmark, Netherlands, UK, and a couple of other countries as well. They randomized patients to a minimum flow rate of 10 liters per minute through an open system or a minimum FiO2 of 0.5 through a closed system with invasive or non-invasive ventilation as the case may be, among patients who are expected to require oxygen for at least 24 hours. While in the conservative arm, the PO2 target was set at 60. And this was, of course, a target PO2 of 90 in the liberal arm compared with 60 in the restrictive arm. So 90 versus 60. And they looked at the 90-day mortality, the primary outcome, not significantly different between the liberal and the conservative arm. Liberal as in 90 millimeters mercury, restrictive 60 millimeters of mercury. The secondary outcomes, including days alive and without life support, days alive after hospital discharge, were also similar between the two groups. So this study reasonably established the fact that you need not aim for a high level of PO2 of 90 or more. You could just as well aim for a PO2 level of 60. So the gist of all these studies seem to suggest that high levels of oxygen of more than 100 millimeters of mercury have, in most of the clinical trials, been shown to be either not helpful or associated with harm. And whatever pointers that we have today seems to suggest that a PO2 level of between 60 to 90, saturation of about 95 to 96% may be okay under most clinical situations.
Thanks, Dr. Chacko. So that's a very comprehensive summary of all the evidence that we have so far. And then, as you said, there are a few landmark randomized control trials which have been published recently, especially in the last 10 years or so. I guess HOT ICU trial is probably the one of the closest, which is quite pragmatic trial and evaluated PaO2 rather than SpO2, because the problem with measuring the saturations, as you said before, predicting what the PaO2 is like, it can be hard. So HOT ICU trial really measured the actual PaO2 in these patients and showed there's no difference between the liberal versus conservative arm. And I guess one of the issue with oxygen is it's a drug. It has got its cost. And And during COVID pandemic, we did see the effect of running out of oxygen and how devastating that was. So I guess we need to use oxygen conservatively as much possible, not just from the harms due to its use, but also from the resource point of view. Especially if the patient doesn't need it, probably there's no point in giving it. One of the interesting fact about these different trials, when you put all the patients together in one trial, most of the trial did not show any difference in the primary outcomes. And most of the trials were not powered adequately for the majority of the secondary outcomes. Having said that, there has been always a signal in some subgroups where at least there was benefit with the use of liberal oxygen therapy, namely septic shock patients from ICU ROCKS trial or ARDS patients with LOCO2 trial. Now, that is something quite perplexing because in myocardial infarction, we had enough signal. Now the hyperoxia is bad. Similarly, majority of the ICU patients who come through the door don't need PO2 of more than 90, 60 to 90 is sufficient. But the patients with septic shock and ARDS patients are the one who need to be a bit carefully watched because there is some signal with the benefit of use of liberal oxygen therapy. And I guess that's something needs further evaluation with better design randomized controlled trial targeting this population. So I guess MegaROCKS program that Paul Young is currently undertaking is probably the one which will probably give us more answers on this topic. But I guess till that point in time, it's safe to say that using the PO2 between 60 to 90 millimeters of mercury, which should be the way to go forward. What's your clinical practice has been in your ICU?
We most of the time follow a saturation of about 92 to 95% in most of our patients, particularly in patients who have high FiO2 requirements. We try to, of course, cut down their FiO2 as much as possible in these patients. For instance, ARDS, severe hypoxia, who need high levels of PEEP and who likely be on ventilation for a long time, we would confine to modest saturation levels of maybe even 88 to 92% under circumstances wherein they are on higher FiO2s for a long period of time. So that's sort of general practice. But in exceptional situations, of course, you may need to be a little more conservative or sometimes a little more liberal as well. For instance, in COPD patients with carbon dioxide retention, obviously the first priority is to ensure that they don't become hypoxic. Hypoxia can cause more harm than the buildup of carbon dioxide. So the priority would, of course, be to supplement oxygen, but to keep it at a level where the body is accustomed to, which may vary from patient to patient, and you need to be able to individualize the care or the target saturation level by the bedside. So most of the time, a conservative approach should be okay, particularly in patients who require higher FiO2s for a long period of time. And the problem here is the fact that you cannot really distinguish between damage inflicted by high FiO2 in the lung compared to the normal pathological changes that you expect in ARDS. So it's very difficult to tell what is causing more harm. So that makes it even more difficult to be sure about whether your oxygen therapy is causing harm. And all the more reason why you should be conservative among these patients. So the more rapidly you wean down their FiO2 to a fairly modest saturation level, the better the outcomes are likely to be from whatever evidence we have so far. And as you mentioned, the MegaROCKS trial may give us more indicators as to the way to go, particularly in patients with hypoxemic ischemic encephalopathy, where there is a high possibility of damage by reactive oxygen species, particularly with reperfusion injury. It is in these patients, we need to be very careful with too much oxygen. And as with anything else in life, oxygen is a double-edged sword, and too much can be harmful.
Yeah, I totally agree with you. And I guess one of the things, as you mentioned, even with the pulse oximetry now, 92 to 94 seems to be the new kind of target moving forward rather than aiming for 96 to 98. And the second important thing is this policy-driven use of oxygen. I think that needs to be relooked at in majority of the hospitals because it initially the prophylactic oxygen therapy was suggested to kind of have a extra layer of protection in case patient do become hypoxic. Having said that there is no evidence to show that this kind of approach saves patients lives or decreases the mortality. So I guess those kind of clinical business rules or policies which are written to just put every patient on oxygen in case they need oxygen. I think that approach definitely need to be changed, and we need to move away from that dogmatic practice in hospitals or in ICUs. And one of the thing with the use of oxygen is majority of times you will see the stats of 98 or 100%, but patient is still on 40% FiO2 on ventilators, because that's where the lowest FiO2 that all intensivists think that's the safest FiO2 to be on. And I guess that's again, it's quite a practice which has been in use for a long period of time. And again, that also needs to be changed, because as you said rightly, probably you need to look at the individualized approach towards the oxygen therapy rather than this kind of one blanket rule, which one size fits all for all patients. So that's probably the best way to titrate your oxygen therapy based on your clinical observations and what actually the patient needs.
What you mentioned is very true. A protocolized approach, like for instance, in patients who are on PCA or any kind of narcotics to administer oxygen routinely, might actually be harmful, because they might actually be hypoventilating, might be breathing at a very slow rate, maybe on the verge of respiratory arrest, and you may not know because you're giving them oxygen and their saturation would be high, 99 or 100%, but they are in fact hypoventilating. So that is one of the problems with just blanket administration of oxygen among such patients. So you need to be careful, and this kind of protocolized management for safety reasons should be relooked at, definitely.
Yeah, I agree. And as I said, that the message is very clear. Oxygen is a drug. So make sure that you use this drug judiciously and be aware of the side effects of this medication. So thanks, Dr. Chacko, for your time today. And again, very special episode as we completed our 100 episodes. So thanks again for your time, and thanks, listener, for supporting this podcast throughout these years. Keep listening, and we'll be back in week's time with another episode. Till then, goodbye and have a nice time.
Thanks, everyone. Thanks, Swapnil. And it's a great moment for us for having crossed the 100 podcast landmark. So we will definitely carry on and wish that you would continue to support our podcast. Thanks for listening in. See you next time. Goodbye.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.